and I'm going to turn it over now. We have, first we're going to have Dr. Mike Schneier. And Dr. Schneier did his neuro residency training at Albert Einstein College of Medicine in New York, with further fellowship training in neuro-oncology at Cedars-Sinai Medical Center in Los Angeles. This was followed by a fellowship in spinal reconstruction with Dr. Ed Benzel at the University of New Mexico. When Dr. Benzel left, Dr. Schneier became the director of spinal trauma and reconstruction at UNM, and he serves the people of this multi-state regional trauma center. So right now he's currently practicing neurosurgery in Las Vegas, Nevada. And I'll turn it over to you, Dr. Schneier. And we have to put this slide up.
Fair enough. When I made my initial presentation to the hospitals to utilize NanoBone, the hospitals basically say, we have all the stock allografts and older technology and including BMP products. Why do we need another product? And my argument for them were, having done CNS transplant work, BMP just maintains the cells in cell cycle and just basically keeps on revving up the cell cycle. So you are throwing out stem cell variants that then have pluripotent potential, and then you get that overgrowth of bone. And I don't know if the community remembers how bad the BMP overgrowth and the complications associated with it. And I just said that, that technology has a black label to it and is not utilized safely. The one thing about NanoBone is that it's uniform and consistent in every application, every modality of treatment. The older, hydroxyapatite, glass, silica sort of activation materials have never been shown to be osteoinductive to form a consistent bony structural regrowth that will actually afford an outcome. So the allografts, including autograft bone, remodel without laying down the new bone formation that will actually be structural. And I basically just drew up some simple basic cases to just say, and today I actually saw a peak implant with bone growing across the implant because of the NanoBone technology. So it gives you a superior bony induction, and then given the enough stabilization reconstruction, you will eventually get a bone formation that is actually structural and making the implantation device sort of moot or indifferent. And I think that's the real advantage of the NanoBone, is it's consistent and it's indifferent to the implant, and you don't get the secondary consequences of it. So these are just basic cases that are everybody is seeing throughout their practice. So, I mean, standard degenerative changes and sort of a loss of lordosis, stacking, you can see end plate changes. The next slide basically shows I have a preference to doing the lateral approach, the transpsoas approach, or the XLIF approach, but you choose a sort of porous implant and you weight bear in the middle column. And this is sort of Dr. Benzel's idea, is that you want to basically reconstruct the middle column, and then by Wolff's law, you're going to get osteoinductive, osteoconductive, osteoinductive bone formation in the weight-bearing column that should be your neutral axis. These are all going to be sort of same standard sort of events. You can see that you have a spondylolisthesis, degenerative changes, common. You can roll to the next slide. You get the implants, you put the implants in depending on what reconstruction you want to get, but you basically are going to try and reconstruct the lordosis and then reconstruct the middle column or the axis of rotation, so people are neutral to weight bearing. And then at that point, then you're going to lay bone down through the osteoconductive process that NanoBone affords you. I happen to pre-fill the disc spaces with NanoBone. I take the dilator tubes that I use for cannulating, load it with NanoBone, put the dilator tube into the disc space, and just use it as a plunger to preload the disc space. If I have bone bleeding from curettage, rasping, whatever, I found that NanoBone just basically filled the void, so to speak, and then I had a clean operative field. So I used NanoBone as a sort of tamponade factor whenever I had bone bleeding, and then I've sort of extended that into sort of cancer cases, corpectomy cases, and such. Next slide. Same sort of degenerative changes, middle-aged female, middle column reconstruction. I do a decompression behind, so I really sort of take down the facets, but you can see that once you create lordosis and you create the weight bearing in the middle column, you're going to have a neutral zone, and within that neutral zone, you're going to get bone formation. Here you have sort of fish mouthing. Depending on people's history, if they smoke or something, you'll do a belt and suspender. But the idea is still the same. You can see sort of the cloud of the NanoBone preloaded, and you can see it sort of forming the bone graft across the implant. You have minimal need for posterior reconstruction if you have restoration of lordosis, weight bearing in the middle column, and then you get a pretty good, consistent, I would think within 6 months, a bone fusion across the implant, and then within the year, like the patient I saw today with the PEAK implant, which is obviously not as structural as the titanium implants. I've seen like, sort of structural bone on plain X-ray in the middle column. So the implantation almost becomes moot at the point that you get that bone fusion, and that's really the goal of spinal reconstruction, is to allow for the bone fusion to make the hardware redundant. The problem with the other implant or bony implants is that the BMP led to horrible overgrowth, softening of the bone, and in some ways hardware failure because the marrow would react in an inflammatory process to the BMP. And then, I'm a neurosurgeon, so I do a lot of revisions. You would see the hardware soften, the bone collapse. The other people, not as much today, would use autograft bone or allograft bone as a primary strut for, let's say, a corpectomy. If you have to redo those, that's a bigger to do, but those struts basically remodel, resorb, and they don't lay down bone across the line, or the Wolff's law, across the line of weight bearing, and you would get some deformity created by resorbed bone, and then angulation and reconstruction is a bigger operation. So your best shot is always your first shot, and I think the NanoBone just gives you so much more consistent outcome than any of the other products. And I was using NanoBone at all the hospitals. HCA has been sort of difficult, but it was really the first hospital I used it, and I used it a lot for tumors and corpectomy reconstruction. And I found in the metastatic cancers, plasmacytoma, multiple myeloma cases, that the NanoBone would just be sucked into the void of sort of the negative venous pressure that you get from that consistent ooze or bleeding, or sometimes even some significant bone bleeding. The NanoBone would just sort of coat it, and it wouldn't obscure your vision. I'd be under the microscope, I could see the NanoBone in the matrices of the bone, and just allow me to continue working to the corpectomy to the level of the ligament. And then anytime I'd get bone bleeding or back bleeding, I would just fill it with NanoBone. I actually tried to send the pathologist some of the NanoBone and see if I can get it on a slide, but once they wash out or they demineralize the bone tumor, all you're left is with tumor, and you don't have the silica or the NanoBone in the specimen. So, but I use it for hemostasis. I use it for osteoinductive, osteoconductive, structural bone formation, supplementing my instrumentation. And I think as a product, it gives you the most uniformity of outcome and consistency of implant. I mean, allograft bone, I mean, in New York, they were digging up people in cemeteries to get the product. So I don't rely on, you know, what they tell you. And that's sort of what my argument has been to the hospitals. And I think that NanoBone affords the greatest safety because it is uniform in its creation.
Thank you. I think we'll actually go on with Dr. Lavelle's presentation, and then we'll open it up for questions and answers.